There we go. Sorry.
Okay, there we go. All right. Gotta love Zoom. Okay. All right, we'll get this started here. So today's talk is on cervical disc replacement, understanding your options. Just to give a little background information, I am from Georgia. I went to Georgia Institute of Technology for undergrad, and then I went to Medical College of Georgia for medical school. Residency and internship and residency were done in Atlanta at Wellstar Atlanta Medical Center. And then I did a dedicated year of training with just spine surgery at the University of Missouri. So to start off with any talking about orthopedics, anatomy is very important. The cervical spine is made up of 7 vertebrae, and there's both bony elements and soft tissue elements. Bony elements, of course, are the vertebral bodies and the joints that make up, that support the movement. And then the soft tissue are also just as important, the neural elements such as the nerve roots, the spinal cord, the discs that separate the bones and give some cushioning and movement as well, including the vasculature and the muscles that support the movement of the neck. This is a more detailed kind of picture of the cervical spine. As you can see, there's a significant amount of anatomical elements that surround the cervical spine. So when there is an issue, it can affect multiple systems. Now, with the cervical spine, it has a significant range of motion. It's a very complex motion. You can bend forward, bend backwards, rotate your neck, as well as laterally bend your neck. And this allows us, to interact with our world. Each level in the cervical spine has a role to play in motion, including the flexion, extension, and rotation. As you can see from this chart here, a majority of your flexion extension comes from the top joint, but the subaxial spine, which is the vertebrae below the second vertebral body, which is what we call the axis, you can see it has a significant amount of movement that contributes to a significant amount of movement in our neck, about 10 degrees of level for both flexion, extension, rotation, and lateral bending. So what are the causes of neck pain, arm pain issues in the cervical spine? Majority of them are degenerative changes, such as degenerative disc disease, which is the fancy term for arthritis. Arthritis can be osteoarthritis, which is the classic type of arthritis, which everyone will experience, unfortunately, and it's due to the cartilage or the disc, which are actually part of cartilage, wearing out and the joints not moving as well as they should. There's also the inflammatory component, such as rheumatoid, which is more due to the body kind of attacking the joints and causing premature degeneration of the joints. Now, the other common issue is trauma from motor vehicle accidents, falls, as well as sports. Now, what can cause, what do these degenerative changes cause? What brings on the pain that you feel? A lot of time, and the majority of the time, when a disc becomes degenerative, it can cause a bulging or herniation. And this can lead to loss of disc height as well as creation of osteophytes, which are commonly known as bone spurs. And there are ligaments that will attach the vertebral bodies to one another, as well as the joints, which can thicken. And they can also become less stable, causing some instability in the spine, all of which can cause pain in the neck and in the arms. Here's a couple of illustrations of some of these issues, and the most common one being a disc herniation or a bone spur pushing on a nerve. The image you see on the left is an axial view of the cervical spine with the spinal cord. I'm moving my mouse around that to show that, and the disc in front. And you can see here that the joints that make up the spine can become big bone spurs, which can narrow the canal where the nerves pass, as well as the image on the right, where you can see the disc herniation pushing on the exiting nerve root, which can also give the same symptoms. Now, when people have these symptoms and they seek medical attention, usually the first step is to get x-rays. And the x-ray allows us to look at not only the bony elements of the neck, but also your overall alignment, as well as note any degenerative changes. The top image is a normal cervical MRI. The spaces between the bones all appear very uniform with smooth edges. And then an image below, which unfortunately got kind of cut off here, and I apologize about that. But at the very bottom level, you can start seeing that the edges, the disc space is not as tall, and you're also getting some formation of excess bone in the front, which is what we would call a degenerative change. Now from there, there are other images that can help us visualize other parts of the spine. A CT scan with or without contrast shows excellent detail of the bony structures if we're looking at something from trauma or trying to judge how much arthritis there is in the joints in the back of the neck. And if we place contrast, that will actually allow us to see the neural elements to see what the bony aspect of the spine is doing to the nerves. Now, for a majority of patients, the preferred study is an MRI, and that is a study that uses magnets to basically help us visualize the soft tissues of the neck, the vasculature, the disc, and particularly the neural elements to see if there's any impingement upon them. Here's an example of a CT scan on the left and a CT scan with contrast on the right. Well, on the left, you have very excellent detail of the bony structures, but as you can see between the bones, you can't really make out the neural elements, which is what the dye is for, which will highlight the spinal cord as well as the nerve roots, and the dye is the white appearing substance surrounding the ovoid spinal cord. As mentioned before, the MRI is our preferred test to evaluate for any type of neurological impingement. And these are two examples of MRIs. The one on the left is a normal MRI. You can see the spinal cord with the white spinal fluid around it. And these two tunnels here are where your nerves will exit. They're called the neuroforamen. The one on the right, as you can see where the arrow is pointing, this is an example of a disc herniation. When you compare this tunnel on the right of the image to on the left of the image, you can see that this tunnel is narrowed. And that would typically where we would see or expect to see some type of issue with the nerve. Now, when you have arthritis of the neck or trauma, it can cause numerous symptoms, most common being neck pain. It can be sharp. It can just be a dull ache. Now, if there's neurological impingement, it can also cause pain going down into whole parts of the arm or specific parts of the arm. You know, if there is neurological involvement, you may notice that your hands are not working as well. You're having trouble picking up buttons, tying your shoes, your handwriting has changed. Along with this, if there's any spinal cord impingement, you also may notice some changes in your balance where you feel more unsteady on your feet. To accompany this, you could have some weakness, which could be due to neurological impingement or the fact that when you use certain muscles, it just hurts. You can also get numbness, tingling, and if compression is very severe, particularly on the spinal cord, you could also notice some bowel or bladder involvement such as dysfunction and incontinence. However, all that being said, you could have very few to almost no symptoms at all. So as mentioned above, we typically will start with the x-rays and then graduate to other imaging as needed depending on the treatment. As mentioned before, MRI shows great visualization of the nerves, the ligaments, and the discs, and the CT scan will show more kind of bony elements. So with everything when it comes to spine, unless there is some type of emergency, we typically start with non-operative treatment. We always encourage regular exercise, prescription strength anti-inflammatories, physical therapy. And if all those fail, the next thing we tend to look for is injections of steroid around the nerves or even in the joints to help kind of calm down the inflammation caused by the arthritis to see if that can give relief of the symptoms. And typically, most patients from research, about 70% of patients with these issues will have good improvement or even complete resolution of their symptoms without requiring surgery. However, if those modalities do not work, there's always operative management. And about 26% of patients that present with these symptoms may need surgery. There's two different types of surgery for the talk that we're discussing today. The first is called an ACDF, which is anterior cervical decompression infusion. This is a very classic procedure. It's been around for many years. And for issues of disc herniations and pinching of nerves, even in the spinal cord, this is the gold standard treatment. Something that's been relatively new, I'm say relatively new, at least the past 10 years, is something called a total disc replacement. Let's talk about these two options. So the ACDF, the classic treatment, is where we go in and remove the disc and take the pressure off of the nerves of the spinal cord. And we place a spacer in between the bones and then put a plate and screws on the front to help stabilize the area to allow bone to form to create one solid area. The reason we do that is when we take out the disc, we have to place something else in there to give stability to the spine, as well as stop movement, because the main cause of arthritis, bulging disc, herniated discs, or arthritis in general, is movement in the joint. So to stop the arthritis, essentially, is you stop the movement. Now, with the fusion, we lose motion at that level, and as you can remember from that chart earlier, there's a significant amount of movement at each level that contributes to the range of motion in your neck. However, all that being said, this is a gold standard procedure. Patients get very good results with this and good improvement in their pain. However, you have the loss of motion. And when that happens, what typically evolves is additional stress on the other levels of the spine that are still working. Typically, how I describe this is like when you're on the interstate and there's a lane of traffic that is closed. All the other lanes are now having to pick up the slack, and they become overcrowded, and this is where you get the traffic jams. That kind of is what happens with your spine after a fusion. The other levels that are still moving are seeing more stress and more movement can mean increased degeneration at levels faster than would normally happen. Going along with this, also when you do a fusion, you're trying to trick your body to grow bone where God did not intend it to grow bone. And sometimes the body doesn't form bone the way we want it to, and this can cause a non-union, which can also cause issues such as instability and require further surgery. So with the development of technology and studying the motion of the neck, a newer procedure has been devised to try to maintain motion at the level of the spine where the nerve or the spinal cord is being pinched, and it's called a total disc replacement, or TDR for short. Just like the fusion, the purpose of it is to remove the compression on the neural elements at that level to improve neck or arm pain. The reason for this, the reason that the total disc replacement is such a good option for those that qualify, is that it maintains motion at that level. Now, it's not the same God-given motion that you had as a baby, but it still maintains motion to take the stress off the other levels. And from good research in 10 and 7-year studies, they comparing it to a fusion, there's been significant decrease in adjacent level disease. Also, when it comes to actual recovery from the surgery, it is typically shorter. We're looking at 6 weeks versus 3 months. Now, comparing this procedure to the gold standard, which is the fusion, the patients typically have higher satisfaction from the relief of their pain when compared to the ACDF, and they also have lower revision surgeries. So we say revision surgery means surgery at another level from adjacent level disease, or a non-union where the bone doesn't form and you have pain from that. There are many types of disc replacements on the market, and I am not a paid consultant for any of these companies, but typically the one that I use is the Mobi-C from Zimmer. And the nice aspect of this disc replacement is it has motion in multiple planes. It can be flexion, extension, lateral bending, as well as rotation. So it is a very forgiving implant and mimics normal disc motion more than others. Now, who is a candidate for a disc replacement? Because this, unlike a fusion, there are certain criteria that have to be met in order for it to have a good result. So first off, continued pain after non-operative treatment. The next is minimal degenerative changes. So people with significant amount of arthritis, significant amount of loss of disc height at the level of concern are unfortunately not candidates for this procedure, as the disc replacement requires certain levels of normal anatomy in the disc space as well as the joints in the back of the neck in order for it to function properly. Along with this, there can't be any signs of instability where there's abnormal motion at the level of the spine, and no deformity such as from trauma where the vertebral bodies or the joints in the back are not normally shaped. Furthermore, you need to have good bone density. The way the implant works is it has teeth that bites into the bone, so if the bone is weak, the implant could subside into the vertebral bone or it could pull out, which we don't want. Finally, no active infection. If there's any type of infectious process going on in the area, we don't want to put any foreign material in there, which can breed the infection and make it worse. Also, and finally, no allergy to any of the components used in the implant. With any type of surgery, fusion, disc replacement, there are always risks. While they're very rare, there's something always someone has to be concerned about when making this decision and discussing with their family if they're a candidate for this type of procedure. First, and the worst, would be any type of damage to the nerves or the spinal cord, which could result in paralysis or loss of function or part of function of the arm. Again, that is very, very rare. Dural tears, tearing the sac that holds the spinal fluid around the nerves or the spinal cord, and that can cause its other issues, but typically this is not a problem, and it is usually, if it happens, repaired during surgery. Just like with any other orthopedic procedure, we worry about infection. Usually it's superficial. We approach the spine through the anterior portion of the neck, which has a good soft tissue envelope, and infection rates with these procedures is very, very low. However, patients with uncontrolled diabetes, obesity, smokers, and those with chronic kidney disease do have an increased risk. There can also be an incidental fusion. When we're doing the work on the disc space, we do cause the bone to bleed to kind of help the implant kind of fuse itself to the bone but maintain motion. There's a medicine called indomethacin that I will give patients after surgery to help decrease the rate of any unwanted bone growth. The implant, like any man-made product, could fail. If it fails, we may have to have a new one put in or possibly convert it to a fusion. While this is rare and there's very little research showing that this happens, there could be recurrence of stenosis from most likely arthritic changes as the disc is removed, so there shouldn't be another disc herniation causing any postoperative issues. And while there still is motion, it is not 100% normal natural motion. So there are still rates of degenerative of adjacent level disease, but as shown from long-term studies, this is significantly less than what has typically been seen with fusions. Now, talking about postoperative recovery, usually this can be outpatient or a one-night stay, assuming no issues. The surgery itself is not very long, depending on the complication and how many levels we do. We're looking at anywhere from an hour to an hour and a half. Depending on your job, you can return to work in a couple days. But for limitations after the surgery, I have patients doing no lifting over 10 pounds for about 6 weeks and no extreme cervical range of motion for 6 weeks to allow the implant to kind of heal to the surrounding bone. Once that 6 weeks has surpassed, if x-rays show that everything is moving normally and the patient's doing well, I'll allow them to start increasing their activity as tolerated. However, within those 6 weeks, if you have more of a clerical type desk type job, you can go back to work when you feel comfortable. Immediately after surgery, it is okay to travel, sleep in your own bed, ride in a car, and of course, when you're no longer taking narcotics, you're allowed to drive. Post-operative physical therapy, it is patient dependent. Typically, most of my patients don't require physical therapy afterwards, but if there's need for kind of help getting back into activity, we can always set up physical therapy. As mentioned before, for appropriate candidates, this procedure is a very good procedure. It has reliable relief of arm and even neck pain, and has very high satisfaction scores, even that above a fusion, which already has great satisfaction scores. The other benefit to it, as we mentioned before, is the decreased need for revision surgery and adjacent level disease because of the maintained motion. So that is my talk for today. I currently see patients at the Tower at Park West. I also have a Facebook page for any additional information. So with that being said, I'm going to do questions. Let's see. So sorry, I'm still learning how to use Zoom, so hang on.
Stop sharing.
I'm going to stop my sharing, okay?
Yes.
Okay.
All right. If anyone has any questions, if you will just tap them in the chat box there. Let's see, we have a few.
Okay.
So you can read them out loud.
Okay, so one of the participants is asking about for lower back, so lumbar disc replacement. That from the research that was done, they typically do not do well. Most insurance companies won't even pay for it anymore because the results from them have not been long lasting. And there are very few people that actually qualify for the procedure, given that most of the issues in the lumbar spine, people have significant degenerative changes that would disqualify them from a disc replacement. That being said, I am not aware of anyone in Knoxville that does lumbar disc replacement. So I don't know if that's helpful or not, but that's all I can say to that today. Okay, another question about the lumbar disc replacements. Like I said, they have been done, but most of the research has shown that patients do not do as well.
Okay.
All right.
And then Martha E., we're going to unmute you. Minimize that.
Sure.
Thank you. And then scroll down. Has to unmute. Martha, I think you can unmute.
I did.
Okay, great. There you go.
Hey, Martha.
Thank you. You answered my original questions, but I have been with X-ray self-fused for trauma and arthritis to my neck. So
Okay.
I don't think that would qualify me for a candidate.
Probably not.
Okay. The other thing is that I wanted to know how I should go about getting evaluated. I had a close friend fall over the dog, and it turned out that the dog was very helpful because she's now had 2 cervical fused
Okay.
because she was so compressed from arthritis.
Yes, ma'am.
And her neurosurgeon said that, you know, if she hadn't had the small fall, she would be quadriplegic.
Oh, okay.
And so that was helpful. So how do I go about proactively trying to evaluate what would be best for me if I think I've got I have a lot of arthritis. So
Sure. So I see patients in my clinic at Park West on Monday, Wednesday, and Fridays. We can get you my office number. I'll have Sloan send that to you, and just call the office, and we'll get you set up with an appointment.
okay.
Okay.
Okay. Very good.
All right. Well, thank you for the question. All right. Okay, so another question about doing a total disc replacement at C6-7 and C7-T1. Both those levels. Now C6-7 does qualify. I would have to do a little additional research on C7-T1, given that it is a transitional segment, basically meaning that going from the cervical spine to the thoracic spine. And for FDA approval for this implant, there are very particular parameters that they suggest physicians follow to make sure the patient gets the best result. So I can tell you right now, C6-7 definitely qualifies. I did I did a 2-level yesterday. Patient's doing great. Now, typically the problem with C7-T1 is anatomically, it can be very difficult to access the front part of the spine. So it can be increasingly difficult to get to that level, just even for a fusion. However, everyone's neck is different. I would have to have x-rays and kind of see what your anatomy is before telling you yes or no. But the Mobi-C is one of the few implants that is actually approved for 2 levels. Most of these are only approved for 1 level. So it's a very good question. I'd be glad to see you in my office so we can go over imaging to discuss if that would be something that would work for you.
All right, can you hear us?
Yes, sir.
Yes, I have an artificial disc in between C3 and 4.
Yes,
Mobi-C.
A Mobi-C, and it's wonderfully.
Year and a half out.
I did in February of 2019, and I had suffered from chronic headaches constantly, and where I was pushing on the nerve, and right after our surgery, no headaches. Cleared everything. Yes.
Fusion.
And I've got what it is. I have fusion between
4, 5, 6.
Between 4 and 5 and 5 and 6. And where I have fusion, I would thought that insurance would cover the artificial disc, but where I had fusion, they said no. So I end up having to pay out of pocket for my artificial disc, but
It was worth it.
it was worth it. I was suffered so much that, it wasn't living, let's put it that
You
way.
got degeneration.
Well,
I
I'm
do
worked out for you. I will say this though, the only thing I can think why insurance did that is that would be what's considered a hybrid construct where you have a fusion at one level and a
Yes.
replacement at another. The FDA did not approve that. Now, there are plenty of physicians and surgeons out there that are doing those, and there's actually pretty good research come out over the past few years looking at the hybrid constructs, showing that there really is no increased risk of the disc replacement failing, which is what they're concerned about, because when you fuse one level and you have still motion at the other, you're putting increased stress, as we talked about earlier. And so the FDA, while it hasn't been cleared yet, is worried about increased stress at the replacement level that could cause it to fail. So that would be my best guess for that.
But I'm the one that has the more generation because I had that fusion up above that. So I need the between 6 and 7 and 7 and T1.
Okay.
So
Could you do artificial discs at those levels with fusion and artificial disc above, or is that getting too complicated?
Well, it's not too complicated. It's just I just said with the increased stress on the implant at those levels. So I can't give you a definitive answer now. I haven't seen any imaging and we haven't done an exam, but I'd be glad for you to come to the office. We can look at stuff and talk about what your options would be.
okay.
Okay.
Thank you.
No, you're welcome. Thanks for coming to the talk. All right.
I think that's all the questions in the chat box right now. Are there any additional questions before we kind of wrap up? Okay.
All right.
If not, thank you all so much for coming. I will be sending out a recorded version of this presentation for your records. If you want to share it, please feel free. And then anyone who wasn't able to join us today will get this recorded version as well. Oh,
hang
Martha
on.
asked.
Martha. Oh, so I operate at Park West Medical Center for all these types of procedures.
Awesome.
All right. Any other questions? All right. Well, thank you guys. I appreciate you taking time out of your day, and I hope this was informative. And as I said, anyone has any issues or would like to have an appointment, I have openings, so I'd be glad to see anybody.
Yes.
All right.
I will also send out in the email a direct link to Dr. Booth's online scheduling, his office number to schedule, and then you can also email us at feedback@tocdocs.com, and I'll be happy to schedule you myself. Thank you so much. Y'all have a great day.